Hello, everybody. Welcome to Palmetto's virtual care conference on telehealth. I'm Nina Antoniotti. I'm the Director of Interoperability and Patient Engagement at St. Jude Children's Research Hospital. I've been working in the telehealth and virtual healthcare space for about 25 years. And today we're going to talk about reimbursement, a big topic. It's always a big topic. I've been speaking on this for years and years and years, and it's very exciting to think about what the future is going to hold for us in telehealth. I had a good friend of mine say to me once, there's no sense in wasting a good crisis when it came to telehealth. It's too bad that on the 66 years of experience we've had in the United States with telehealth, it took a pandemic to get us where we are with telehealth reimbursement. But, I'm not going to look, I guess, a gift horse in the mouth here. And we're going to talk a little bit about what some of those changes are. I will be monitoring the chat box for questions. So as you think of your questions during our session today, please go ahead and put them in the chat box, and I will also respond in the chat box. When we think about the effect of COVID-19 and a worldwide pandemic, basically, there's lots of important things that have happened, but some unusual and interesting things have happened as well. The germaphobes probably are a lot happier. We can no longer shake hands. I heard the other day that people no longer blow out candles on birthday cakes. Safe sex probably now involves some sort of plexiglass. And the concerts that are being held, if there are concerts, have signs up that say no dancing or singing or standing. I'm not sure why you would go to a concert if you can't do any of those things. And no more condiments. We can't pick up salt, we can't pick up pepper, and certainly not those tiny little ketchup packages. There's two really great effects of COVID-19 on our society. Hundreds of thousands of animals have been adopted from animal shelters. When I think about that and people staying home and having time for pets and pets becoming an integral part of our families, it's, again, some really positive things have come out of COVID. And of course, the other is telehealth and telemedicine. It's really interesting after being in this field for 25 plus years that now telehealth is the greatest thing since sliced bread. I can't tell you all the times people have told me it doesn't work. Patients don't want to use it. Providers think it's hocus pocus. I was even called the devil incarnate one time when I was trying to explain telehealth for kids in New Mexico to receive mental health services. We've advanced at least 10 years since March of this year in payment policies and public policies surrounding telehealth and telemedicine and virtual care strategies. We've been fighting the battle with the CMS for 22 years, and in a mere 2 weeks, we got almost everything we've been asking for over 2 decades. And I find it interesting that the first time I heard the word telemedicine or an advertisement for telemedicine on TV, I perked up like, someone told me I won the lottery. So we see telemedicine everywhere now, advertised on TV. Everybody's using it. Everybody has experience with it. I think the Medicare population went from something like 2% of Medicare beneficiaries having access some telehealth to 68% of Medicare beneficiaries being able to use telehealth today. When we think about reimbursement, then, of course, we wouldn't see the proliferation of telehealth if there hadn't been some sort of payment that goes along with it, particularly in today's COVID world when all of the money-making initiatives that healthcare systems have in place, like surgeries and elective procedures, simply stopped. There had to be reimbursement, there had to be payment for services delivered by telehealth. And what really drove that for us was essentially the inability to see patients in person. our providers at St. Jude couldn't go to work. We sent everybody home except those people who had to see patients in the hospital. Patients were afraid to come to our healthcare organizations. They were afraid to go to emergency departments. We had significant issues with patients who wouldn't seek stroke care. We have exposure of our EMS personnel, lack of PPE, and then cancellations and closures. So when you think about all of those things on our healthcare system, we were essentially in crisis. And when crisis is standing at the door, people do very interesting things. They become innovative. They start to work together. And that's what we saw with our policies for telehealth reimbursement. On March 27th, Congress passed the CARES Act, which is the Coronavirus Aid, Relief, and Economic Security. And in the CARES Act, Public Law 116-136, we had significant legislative mandates to start to come up with payment policies for telehealth during the pandemic period. Now, the pandemic period officially ends January 31st of next year. I'm not sure it will end then. It may be extended, particularly considering what's going on in my home state and many of our states, with Wisconsin having the highest death rate, the highest hospitalization rate. And, you know, it's essentially a rural state. So we have not seen the end of it. We're not even nearing the end of COVID. A lot of cases are going down. A lot of hospitalizations are going down. But we may not see the end of the pandemic emergency orders in January. But currently, they are extended to January 31st. When we think about CMS, again, CMS has led the way in many ways, and I mean led the way in terms of being the barrier for years and years and years, and then in the last 3 to 4 years, suddenly, you know, having some sort of brain transplant and have really shown some leadership in telehealth reimbursement. Excuse me. There are about 400 different kinds of reimbursement waivers for healthcare. Mixed in with all of those are the waivers and the emergency orders and the policy changes for telehealth. And we're going to go over quite a few of those. We can't go over all of them. I encourage you to look at this particular document from CMS, which explains a lot of what the changes CMS has made. But in a nutshell, when we think about Medicare, and in addition, there was an executive order mandating that the secretary come up with additional services for telehealth for rural areas. Now, this doesn't give us anything. It didn't mandate, it didn't outline, it didn't really kind of tell HHS they had to do something. It is a recommendation to the secretary. And so we have some opportunities here again through call to actions, through legislative efforts, calling your congressman and letting them know that we would like some of the changes that we've seen during COVID that benefit everyone to be continued. I know this slide is really, really small. It contradicts everything I've ever learned and taught people about giving presentations, but it's kind of important to list out some of these things so that we know what happened, what's in place now, what the future might hold. There certainly is a waiver in place for rural health clinics and FQHCs to become the distance site practitioner. They provide a lot of services. Obviously, they couldn't be the distance site practitioner according to CMS for Medicare beneficiaries. Now think Medicare beneficiaries can't come to the office, they stay home, they won't go anywhere, they're a high-risk population. How can you not reimburse an RHC or FQHC for providing services via telehealth? Again, remember, these only go to the end of the pandemic. Audio only Services were instituted by CMS. Again, that entire list of services is not the entire list of telehealth services. It's some of the services, but not all. Telephone E&M services for 99441 to 443 was added to the list of Medicare eligible telehealth CPT codes on March 1st. So you can provide services by telephone, evaluation and management services, and you can get reimbursed for those. What's interesting is the definition of telehealth for Medicare is two-way live interactive audio and video, but they have added these to the list of Medicare eligible telehealth CPT codes. Again, the 1834, the restrictions in 1834 in terms of geographic location have been lifted. And so even though these codes are on the list of Medicare eligible telehealth CPT codes, they're not subject to the geographic restriction. Coinsurance and deductibles have been waived for COVID-related E&M services. So if you are evaluating a patient, if you're triaging a patient, if you're doing lab work, if you're collecting samples, any E&M services that have coinsurance and deductible attached to them would be waived if that patient is being evaluated for COVID. Again, they did not add to the list of Medicare CPT codes except for the telephone. So again, there weren't a lot of additional services added. There were a few, but again, not everything that we would like to do. One great thing that CMS did was allow any Medicare eligible practitioner to bill for services during the public health emergency. This is something we've been asking for since 1998, so 22 years. Excuse me. This is a very, very, very important milestone. And when I talk about what the future brings, this was a good move on the part of CMS, and it's something that we can build on. They also expanded, CMS also expanded the ability of non-eligible practitioners. So these would be respiratory therapists, physical therapists, people who are not eligible practitioners under the telehealth restrictions of 1834 to bill incident 2 under a qualifying practitioner. So again, if a respiratory therapist is seeing a patient on CPAP or an apnea monitor, or is working with a patient with congestive heart failure or COPD, those services are now reimbursable if they are billed incident 2 under a qualifying practitioner. CMS also allowed for what's called consumer grade, open architecture, non-HIPAA compliant video conferencing platforms like Skype, FaceTime, Google Talk, really any way that you can interact with the patient that is sufficient to do a clinical exam. And that is the key. You cannot use Skype for a complex cardiology patient and bill a level 5 99215 CPT code if you can't listen to heart and lungs, you can't see the patient, you can't evaluate their feet, so forth and so on. Because of the proliferation of HIPAA compliant software, I have always recommended to people that they continue to try and use HIPAA compliant video conferencing platforms. In the end, if something were to happen, you had an adverse event as a result of a telehealth visit and you were on Skype, you know, next summer when COVID is over and the pandemic waivers go away, you know, we're not really sure what the legal system will do with those types of claims. So I still recommend that people try and use their HIPAA compliant clinical video, you know, PECSIP, Cisco, Jabber, some of those that are just as easy to use as Skype and FaceTime. I still recommend people use those. CPT codes 98966 to 6H, which describe audio-only telephone assessments and management with healthcare practitioners who cannot independently bill for an E&M phone visits. Those are now, those providers are now eligible to bill and be paid for those. There are changes in the requirements for the days of service. So the days per month for remote patient remote monitoring, those changes have made it easier for people to use RPRM for shorter periods of time and be paid. The home is included as an originating site with no facility fee, and temporarily CMS has added the emergency department E&M codes, the critical care codes, and the observation codes to the list of Medicare telehealth services. So as we think a little bit more about what the future might bring, I would say, if I had to bet a margarita with everybody on the call today, we would keep telephone services. We would allow for any Medicare eligible practitioner. We would remove the geographic restriction, and we would add the codes listed there at the bottom for ED, critical care, and observation codes, and we would not have a geographic restriction. When you think about it, that's everything we've been asking for years. When we talk about Medicaid, Medicaid again is the same animal it was prior to COVID. Every state is different. The feds did not mandate in the CARES Act that Medicaid follow any particular regimen. It's a state-by-state issue again, so you have to look at your Medicaid waivers, your gubernatorial emergency orders. Many governors have waived the restrictions that a state Medicaid agency would have had for telehealth reimbursement. Again, it's not a simple task, particularly if you're a nationwide telehealth company. I encourage people to continue to try and look at each particular state. If you have questions about that, I can certainly help you. But many of them did follow the CMS Medicare waivers. That did make it easy for people in the state to understand how to get reimbursed under COVID. Most of them included home as a site of service if it was not already included. If states have a parity act that mandates payment and access, so equal payment and equal access, the home would have already been a site of service. Most Medicaid agencies expanded eligible practitioners to allow for some of the allied providers who were not on the list of eligible practitioners to be able to see patients by telehealth. COVID-related services are typically paid by telehealth in almost all states. So if you're seeing a patient to determine whether or not they have COVID, to do an assessment prior to labs, or to care for a patient who has COVID and is recovering at home, those services are typically paid by Medicaid agencies. Few states, again, really are allowing out-of-network providers or unenrolled providers. My organization sees patients from almost every state in the country. We do bill for patient care to insurance plans. We don't ever bill the patient, but we do bill health plans. We do bill Medicaid agencies. And, the governor of the state may have waived the licensure requirements, but that doesn't mean that the Medicaid agency waived the network requirements. So if you're not enrolled in the Medicaid plan in a particular state, most states did not waive those requirements for COVID during the pandemic period. Some did, and so again, it's important to go to each particular state and find out what their pandemic waivers are and what their gubernatorial orders include. Health plans were somewhat more innovative in their approach. The Blues came out right away saying we're waiving all of our restrictions, please use telehealth. The difference is that the direct to enrollee proliferated. So almost all health plans do have their own DTE program that contract out with MD Live, Carina, Teladoc, a lot of those types of companies to cover urgent care type situations for their enrollees. Those services did increase significantly, but the health plans also were paying private physicians to care for their own patients over telehealth, where previously they had not. They waived copays and deductibles for COVID-related care. They encouraged telemedicine online visits, and they included home as a site of service. This is not new for most health plans who had a DTE program in place prior to COVID, because obviously the patients are being seen in the home. But some did expand the home as a site of service for other practitioners who were not a part of the DTE program. And almost all of them expanded mental health services and expanded those services into the home. So again, health plans, there's a bazillion of them. There's, 400 in Wisconsin. There's probably 40 different plans in Tennessee. There's 3 or 4 Medicaid plans and Medicare Advantage plans. Every one of those health plans has their own set of rules. So I would start with the gubernatorial executive orders, look at the parity laws, then go to the Medicaid agencies, and then look at your health plan, individual health plans, what waivers they've issued, what policies they've issued. Molina has some interim COVID policies that they've implemented. They have a whole set of rules and regulations during COVID for mental health that are greatly expanded from what they had before. So again, most health plans have been very innovative in trying to maintain services, prevent people who don't need to go to the hospital from going there, and also providing the COVID-related services. So the question comes, where do we go from here? When I've watched this whole process develop, and when the secretary said in, I think, probably early June or late May, there's no going back from here. There is no going back. You cannot have 68% of Medicare beneficiaries accessing telehealth from their home and then tell them one day they can't do that. You can't have so many Medicaid agencies paying for services in the home and paying for telehealth and then tell Medicaid recipients, nope, sorry, can't have that anymore, just because a pandemic executive order has expired. This is an amazing opportunity for us as healthcare systems and healthcare clinicians to lobby, to advocate for our patients, and to respond to comments by CMS or Medicaid agencies or any health plans as to where do we go from here with telehealth reimbursement and payment. And so where I think we're going is, again, it will be very hard to go backwards. I believe that originating sites will include the home. We have proven what we've been saying for 2 decades, that you can provide services in the home. You can do that safely and accurately. You can, the patients do have benefits and do get better, and they like it. For years and years and years, I wish I had $1 for every time CMS or a health plan said, but patients don't like it. We'd all be in the Bahamas right now. Well, I guess we wouldn't be, but at some point we would be. The geographic restriction will go away. We've been able to prove that there's no difference in a person who lives in a rural area than someone who lives in an urban area. I'm a little disappointed in the executive order from August 3rd that it focused on rural areas again. I believe that does take us a little bit backwards. Again, there may be lack of access because it's not geographically located, but we've proven the case that the geographic, distance and time simply goes away when telehealth is available. I believe we'll continue to see all eligible practitioners be allowed to use telehealth and get paid for that. And I really think, particularly at the level of CMS, that we're moving away from this concept of, telehealth services as defined by Section 1834 of the Public Health Code, and really looking more at healthcare services delivered through technology. CMS took that position 3 years ago with the brief virtual visits, the patient-generated data, and remote patient monitoring. They did not call these services telehealth because they did not want them subject to the restrictions of 1834, and the primary one there is the geographic restriction. Telephone services, I believe, will stay as well, maybe not as broadly defined as they are now. But again, with the move to the interprofessional consultations that CMS made 2 years ago, it's apparent that they see that there is value in telephone services, because the definition of the interprofessional consultations and the requirements for the no services within 7 days of the interprofessional consultation, I wondered where all that came from. And so I looked it up. It came from the definition of telephone services from something like 1978. And so I believe we'll continue to see telephone services being paid for, maybe not to the extent they are now, but certainly it will become a valuable reimbursable part of the care we deliver. I also think we're going to see a change in the way of adding services that may be more streamlined and different than the physician fee schedule. The ability to go to CMS, sit down with them, send I helped draft several memos to the White House staff this year, and several of the sections actually turned into executive orders or turned into CMS policy changes. So I believe those types of communications and emphasis and modalities will be important in changing and adding services, and not so much effort on the physician fee schedule. What we've asked for, again, to include for 20 years, we simply got in a matter of days, and it will definitely be difficult to go back. The downside to everything that's happened since March in terms of telehealth reimbursement is what we've been told for years by the agencies who pay for services delivered by telehealth, is the whole question of fraud and abuse. And we have maintained in the telehealth industry that nobody's here to take a video camera and go to a skilled nursing facility and videotape 200 residents and then drop 200 bills that day. We have not seen any large fraud and abuse claims. Even the OIG's report on telehealth that came out, I think 3 years ago, was basically 100 claims out of 17,000. 68 of those claims had problems. Most of the problems were the fact that the patient was not in an eligible geographic location. A few of the problems were wrong CPT codes. A few of the issues were ineligible practitioners. And so I believe that report showed that we need more education. People still don't understand how to bill for services delivered by telehealth. And of those 68 claims, we really don't know if that was one practitioner or one organization. However, and the only real concern we had that developed over the years was internet prescribing, the whole issue with the Ryan-Haight Act. Unfortunately, because of COVID and the pandemic and the rise and use of telehealth, and every person coming out of the woodwork to try and do this, software companies, vendors, online care companies, we have seen a significant amount of fraud and abuse. And so that for the first time ever in the history of telehealth has raised its ugly head. Pushback in terms of keeping some of the innovative approaches that have been implemented for COVID will be, I believe, solely resting on the fact that we have to, as a legitimate telehealth community, help to dispel the fraud and abuse that's occurred. And honestly, it's in the areas of overcharging, of having a telephone visit and using an E&M code for a virtual visit. And some people are just, downright trying to fraud the payers. So we, again, as a community, will need to be fighting that battle. We've reached out for the brass ring for 22 years, and it only took a pandemic to get it. We have in hand now many, many, many reimbursement policies from Medicare, from Medicaid agencies, and from private payers. Our work now over the next 3 months is to ensure that payers understand the benefit that they have given to their enrollees and their beneficiaries and their recipients, and to make sure that we maintain and retain a lot of these policies. I'd be remiss if I didn't take a minute to thank all of our colleagues on the line. I myself have not taken care of a lot of COVID positive patients, but I am the designated person on our telehealth team to don the PPE and go and help patients and their families get set up with telehealth. It's a remarkable time for us as healthcare workers, an exhilarating but also sad time. And please wear a mask. No one can say that enough. And it truly, with the news this morning about our president and the White House staff, it's now more important than ever. So thank you very much, everybody. Again, if you have entered questions into the chat, I will be answering the questions in the chat box. We have a little bit of time left, so let's have a dialogue there. If you don't know how to open your chat box, I believe you just click on the little sort of comments icon at the bottom, and the chat box will open, and you can enter comments there or read the comments from others. Thank you again. Please stay safe, be well, and wear a mask.